much for the invitation. It's a great pleasure to be back in Berlin. Some of you know that I spent some time here 27 years ago as a British Army officer when I frequently drove up and down Friedrichstrasse, exerting our right to drive up and down Friedrichstrasse and straight through Checkpoint Charlie without any interruption from the then East German border guards. And Berlin has changed incredibly in the years since then, and it's great to see the city as it is now. So I have a completely impossible task. I have an hour to talk about reducing health inequalities, a task to reduce health inequalities that has defied many, many other people. But let me try. I want to start off with a report that you're all very familiar with, and this is Michael Marmot's report and his commissioners, the report of the Commission on Social Determinants and Health. And it made a number of recommendations, and the recommendations were to improve daily living conditions, fine, to tackle the inequitable distribution of power, money and resources, to measure and understand the problem, crucial, and to assess the impact of action. But before we do that, I'd like to just reflect a little bit on inequalities more generally, because we've been focusing largely on social inequalities, but people are divided in many other ways. I often do an exercise with my students where I get them to stand up if they meet particular characteristics. If they need assistance with their eyesight from glasses or contact lenses, if they're left-handed, if they have a particular colour of hair or something like that. And ultimately, everybody is a minority at some stage in some way. But we're divided by gender, by age, by occupation, by income, by wealth, by social class, by whether we live in the countryside or in the city, by education, ethnicity, religion, language, disability, and liberty, whether we're in prison or not. And all of those factors, every single one of them, will impact in some way or other on our health. And the question that we have to begin by asking is, which of these inequalities are we seeking to reduce? The challenge, of course, is the messiness of life, the complexity of life, because these often coincide in a quotation I've taken from the 1980s of how deprivation of various sorts can lead to ill health, damp housing leading to increased amounts of respiratory infection, household overcrowding facilitating the spread of infection, inadequate diet, failure to perceive the importance of illness, stresses, a generally poor physical environment, together with the everyday strains and stresses. So, that's just looking at some of those. There are many, many others. It seems to me that if we want to understand how to reduce inequalities, we might start by trying to work out what the particular problem is. This is a figure with which I suspect everyone is familiar with. It's from Goran Dahlgren and Margaret Whitehead, trying to understand the broader determinants of health. And we can take that list of how we're divided and map it onto that, the gender, the age, where we live, individual lifestyle, and so on, and it all fits onto that diagram, but it maps onto different places. And maybe we can illustrate this by looking at two examples of inequalities. Gender inequalities we've already heard about. Men die before women everywhere, almost. But the gap is wider in some places than in others. And if we simply look at our own European Union, we can see that the gap varies between about 2 years up to about 15 years. That is a phenomenal difference. Now, the genetic composition of men and women in Latvia is not that much different from the composition of men and women in the Netherlands and the United Kingdom. So clearly something else is going on. How can we explain that? Well, we can explain it by understanding that there are some populations where we don't actually see a gender gap. They may be atypical populations, but it is often the exceptions that provide us with the answers. Polish Seventh-day Adventists, that's a particularly unusual population. But they're interesting because they don't have a gender gap in life expectancy. And in fact, if we take the map that we've just looked at, we correlate per capita alcohol consumption in each country with the gender gap in life expectancy, the correlation is about 0.7. So lifestyle factors are important in this population. Other research from Finland showing that about 50% of the gender gap can be directly attributed to smoking and alcohol. And we had the example already of Denmark. We published a paper in this over a decade ago wondering why life expectancy in in Denmark and Sweden had been almost the same in 1970, and then the gap opened wide. And the difference was, as has already been noted, primarily smoking and drinking. So for this inequality, gender inequality, with large inequalities in some countries and narrower in others, lifestyle-related factors play a major role. And here we see one of the paradoxes, because in many countries that gap is narrowing, the inequalities are closing, and that is because young women are adopting the same habits as young men have traditionally had. So life expectancy for women in a number of European countries is actually falling. Let's look at another inequality, the inequality of race in the United States. The boys are in blue and the girls are in pink, in different shading, with different intensities. And we can see that for both men and women, there is a very significant gap in life expectancy. Well, let's look a little bit further, because we can look not just at deaths from all causes, but we can look at deaths from causes that are preventable by timely and effective health care, amenable mortality. And if we do that, and we look at what's been happening in each American state, we can see that for the white population, yes, rates everywhere are relatively low, not as low as they are in Europe. But for the black population, and each line is a state, and we're looking at it over time, there is almost clear water between the black and the white rates in states. The only state, the one at the bottom, where we see very little difference between black and white, is Hawaii, a state that is somewhat atypical, and whereas we know from the stellar elevation of one of its African-American sons very recently, has an African-American population that is somewhat different. The one just above it is Utah, another state that is atypical. So for this population, a major factor is access to health, to high-quality health care. There's an obvious solution to this. The obvious solution is, of course, universal health care, and if we poor, deprived Europeans can do it, it is a puzzle why the world's remaining superpower can't, but it does seem to be rather difficult for some reason. And if that is too difficult, there is plenty of advice as to what can be done in the meantime. Interpreter services, outreach workers, etc., etc. The Commonwealth Fund have written in this, the Agency for Health Care Research and Quality, the Association for the Advancement of Coloured People, and others. So much could be done to close this gap, but in this area, I would suggest that healthcare is a major factor, unlike the gender gap. But then there are areas where we don't know what the differences are, or why they're there, or we can't agree on them at any rate. And these are from two papers published very recently, looking at the gap in life expectancy between Finnish-speaking Finns and Swedish-speaking Finns. One paper suggests that it is social capital, it is the social networks. Structural cognitive social capital is much higher in the Swedish population. Social capital explains to some extent the health differences. Another paper from a different group talks about how Finnish-speaking men and women reported more frequent drunkenness, more frequent hangovers, and had more alcohol-related pass-outs than in the Swedish population. And it seems unlikely that social capital is mediated through the drinking pattern. So which is it? Still some work to do there. Other example of where you have two populations that have very similar levels of life expectancy, but the diseases, the causes of death contributing to the life expectancy are quite different. So only when you look within the causes do you see the inequalities. But there are still many questions to be answered. Well, how do we make a difference? What is successful? What will work and what will not work? Karl Marx famously reminded us that the philosophers have only interpreted the world. The point is to change it. We as public health researchers, like philosophers, have been remarkably good at measuring and understanding inequalities in health. We still have more to do, but that is where we have really made our mark. We have made the invisible visible. We have shown the world that there are differences in our health experiences. We have been much less successful in discovering what to do about them. We can look for the usual sources of evidence, the Cochrane Library, and I know it's a bit difficult to read at the back, something I never do, but it's a screenshot from the Cochrane Library, and you'll see that it tells me that your search, inequality, did not match any documents. No pages were found containing inequality. Suggestions, Make sure all words are spelt correctly. Try different keywords. Try more general keywords. So that doesn't help us very much, does it? Yet we all know what is the right thing to do. What is the right thing to do? And we don't need research to do this. We know that giving very poor people money is a good thing to do. We know that giving people who are hungry food is a good thing to do. We know that giving people who do not have access to clean water is a good thing to do. We know that it's a good thing to protect people from violence. We know that it's good to give everyone adequately remunerated, satisfying and rewarding jobs. We know that it's good to build healthy and safe environments. And we know that it's good to stop other people, be they warlords in the Democratic Republic of Congo or the executives of tobacco and alcohol companies, from killing them. Those are all things that we should be doing anyway. Now, do they have an impact on inequalities in health? I don't know. But I don't actually think that it matters, because they are the right thing to do anyway. And the other thing you can do is vote. And we all have elections coming up in the next few weeks, so you have a chance to do that. This is the Gini coefficient in the United Kingdom, corresponding to different political parties in power. Now, we have a colouring problem for the last stage. You will know that we have had New Labour in power in the United Kingdom for the last decade or so, and I've coloured it as pink because it sort of started off left-wing, but we now have rather a reversal as the originally right-wing party has moved to the left and vice versa. But generally, you will see that certainly under the Conservatives in the 1980s, inequalities grew considerably. Did that impact on health? Well, yes it did, but the relationships are complex. So that's it. I'll sit down now. I've said all there is to be said, or maybe it isn't. Maybe there is something more that we can say. Maybe the question is not what strategies work and what don't, but the question perhaps is how do we improve the health of the most disadvantaged? Bearing in mind what has already been said, that this is often challenging. Our general policies may widen inequalities even while improving the health of everybody. There is some good news that we can take away. The emphasis of research in public health is gradually moving from identification of the problem to diagnosis, to understanding why inequalities exist, and to prescription, to understanding what we should do about them. We are identifying different entry points. The Determined study is a beautiful example, intersectoral working, recognizing that health is not often the primary reason why people are engaged in public policy, but we can find win-win solutions and growing experience in developing, implementing, and crucially in evaluating interventions and policies. But the bad news is that the pathways from disadvantage to ill health are often highly complex. People rarely have only one risk factor. Poor people rarely have only one harmful behaviour, they only have only one aspect of social disadvantage. There are confounders, epidemiological confounders, everywhere. There are variable timelines. There are endless studies, mainly from the economics literature, looking at smoking rates today with lung cancer rates today, totally ignorant of the fact that there's a 30-year time lag between starting smoking and getting lung cancer. Interventions are difficult to implement, and they are beset with unintended consequences, some of which we'll see later. There is a profound reluctance among policymakers to subject their beliefs, their dreams, their fantasies, and most of them are dreams and fantasies, to evaluation. So we're dependent on natural experiments. But natural experiments can be extremely misleading. We use the term ceteris paribus, all else being equal, but the tragedy is that all else very rarely is equal. And context is tremendously important. Take the role of cycle lanes in improving health. If you're lucky, you have a Dutch cycle lane in which you can actually cycle along. If you're in England, and this is very near to where I live, you have a cycle lane where you can only cycle along it if you have a unicycle. In the Czech Republic, you need a BMX bike and a considerable ability in acrobatics to negotiate the cycle lane. So just because we compare the effectiveness of a cycle lane, and we demonstrate that a cycle lane improves health in one country, don't assume that it will mean exactly the same in another. So the first steps in understanding successful strategies, I think, are to decide who are the disadvantaged groups, to discover how they're disadvantaged, to discover how this is impacting on health, then to identify where it may be possible to intervene, and then find the evidence. Finding the disadvantaged groups seems easy, but it's not. It's a challenge. Many of them are invisible. They're the people who clean our offices but leave before we get to work or come in after we've left work. They're the people at the end of the food chain, the people who are picking the vegetables and the people who are preparing the shelled prawns. How do you think that prawns come to have all their shells taken off them? It doesn't happen by magic or by machinery. These are the people that we don't include in surveys, sometimes because they don't want to be included in surveys, because they don't want to come to the attention of the authorities, because their experience is that authorities are nasty to them and do horrible things to them. Where do we find the evidence? Well, actually, I was being unfair to Cochrane. The Cochrane collaboration does have a wealth of evidence on what works to improve health. It just doesn't look at inequalities. Hopefully, many of you are familiar with the Campbell collaboration, which is probably more helpful. It has areas such as education, social welfare, criminology, and a very rich source of systematic reviews. So, for example, it has a systematic review on strategies to combat terrorism. If you want to find out if airport screening works, you look there. The answer is it doesn't. In fact, none of the counter-terrorist policies work, and most of them make things worse. But those are the sort of things that it includes. So to try to, once we've identified the individuals, once we've found some evidence, how might we move forward? Now, I've taken this classification from Goran and Margaret, okay, because I think it's quite helpful. The categories that I've used, the examples, don't exactly fit, and maybe they could go into different parts of it, but it's a useful way to start thinking. Looking at individuals first. I think here the strategy should be to focus on the big issues and help people to make healthy choices. And let's just stick with smoking, because everywhere we look, smoking is a major driver of differences in life expectancy by education, by social class, by gender, by whatever. We know from experience that generic campaigns widen inequalities. The best educated, the more advantaged, take advantage of what is available. They learn, they change their behaviour, the others don't. But there is still much more that can be done in terms of targeting interventions and ensuring that the policies are directed to those who are in greatest need. Do we have evidence? Well, we do have evidence, and I just simply use this not to look in detail at the evidence, but to say that the evidence exists. There are a huge number of policies implemented to combat smoking that are totally useless, most of them supported by the tobacco industry. Programs directed at children, child health, child anti-smoking campaigns, sponsored by Philip Morris, which tell children, you should not smoke because you're a child, smoking is an adult thing to do, and governments buy into it. Actually, this government has had a record on that as well. So there are things that don't work, but there is evidence of what works. These are simply a few examples of where individual interventions might work. Another example of who might deliver individual interventions. The detail is not important. But of course we do know that with smoking we need a multifaceted programme. With everything we need a multifaceted programme. And the challenge for our societies is to recognise that there is a spectrum of smoking that goes from California on the one side, maybe Bhutan where there are no cigarettes, but California where it is extremely difficult to smoke, to China where, if you've been following the news this week, there is a province where it is now compulsory to smoke. So where do we sit on that spectrum? How do we move our countries from one end to the other? Clearly, Germany is now to one side of closer to China than the United Kingdom. Austria is even further away. How do we actually manage to bring about that change? But there is a lot of evidence there. I'm simply highlighting that the evidence exists. But what about strengthening communities? What would be a desirable community to live in? Forget health. Because if you get a desirable community, I argue that many of the health challenges will be addressed at the same time. Imagine that I'm an estate agent telling you what part of Germany or what part of Berlin to live in. Somewhere nice out in Potsdam, somewhere like that. What would it look like? It would be an area with lots of economic growth, with jobs, pleasant environment, parkland and so on, low levels of crime, high levels of education. And this is a reminder that if we're going to tackle inequalities, we need to look more broadly than health. What works in terms of increasing jobs or getting people into work, people who are long-term out of work? Well, a controversial proposal, but it works. Welfare to work, developed in the United States and Wisconsin and some other states, now being taken up by a number of European governments. And we're seeing that this is a way of getting people who have been out of work for a long time into jobs. And we know consistently that those people who don't have jobs have worse health than those people who do have jobs. And it's not just money. One Italian study gave the unemployed 100% income replacement. They were still less healthy than those people who are in jobs. Work is actually a good thing to do. So that's one area where we can look at communities. And I'm being highly selective. I couldn't possibly hope to cover all of the areas we could talk about without keeping you here for the next 3 weeks. Health and the environment, a healthy, safe environment. I'm saying relatively little except to refer you to a paper we've just published in the International Journal of Epidemiology, which covers this in much more detail. But to summarise it, it's not just the reality of the environment, it's the perception of the environment. Perceived safe environments and attractive environments encourage people to take physical activity. But also objective measurements of walkability are associated with physical activity. Compare rural Nepal, where it is essential to walk everywhere, with Los Angeles, where if you try to walk, you're at risk of being arrested, as happened to a former student of mine, because nobody walks in Los Angeles. You just don't do it. You're clearly a deviant and need to be locked up for public safety, if not for your own. We know that the density of fast food outlets is associated with obesity. So there's a rich literature here, a lot of evidence that we can draw on. What about changing your environment? Well, it's quite difficult to do work in changing the environment. You need to get the housing department, the transport department, everybody else involved. What about moving people? And I thought this was an interesting study to understand what the effects might be. And again, I suppose many of you are familiar with it. The Moving to Opportunity Project. A project in which 4,500 families in a number of American cities were randomly assigned to 3 options. 1, give them a voucher which entitled them to move to public housing in a wealthy, relatively wealthy area. 2, give them a housing voucher that allowed them to move anywhere they wanted, including another poor area. These are people in poor areas. And a control group, they get public housing but they don't get anything else. So what happens? Well, it differs depending on whether you're a boy or a girl who's looking at adolescence. The girls moving to wealthier areas improved their educational attainment. They had better mental health and they were less involved in crime. The boys, on the other hand, were more likely to be arrested when they moved to the rich areas. They were more likely to drink, to smoke, and to use marijuana, and a significant increase in injuries that were not associated with sports. So what do we conclude from that? Well, we conclude that when girls are in a wealthier area, they aspire to upward mobility. They look at what's happening around them and they say, I can be like that. The boys say, I haven't a hope. The only way I can get anything is to steal it. I'm simplifying greatly. But that, I think, highlights the consequences of the unintended consequences of change. And that is why we do need evaluation. We cannot simply assume that what seems like a good idea will actually work. Well, I said that a low crime environment is a good place to live. And there is good evidence that people living in low crime areas have better health. A Swedish study, for example, showed that those who lived in violent neighbourhoods had a higher incidence, almost twice as high, actually, or 1.5 times as high incidence of coronary heart disease after adjusting for all of the traditional risk factors. And that was attributable purely to living in the more violent neighbourhood through mechanisms that you're familiar with related to stress and so on and so forth. So if we can reduce crime, it seems like there might be a beneficial effect. And again, we look at the Campbell collaboration for evidence, and there is evidence. Crime is not inevitable. Non-custodial sentences, well, difficult to interpret actually. We often say that jail doesn't work, we should be sentencing people to community punishments, but actually the randomized controlled trials are not so conclusive. Closed-circuit televisions are good at reducing vehicle crime, although not at much else. A message that I would hope that the British government would take on board, saying we have more closed-circuit TVs than the rest of Europe put together. Improved street lighting is a good idea. Enhanced policing of known crime spots is a good idea. Mentoring of juvenile offenders is moderately effective, particularly for dealing with delinquency and aggression, but less so in terms of their low achievement and drug use. And emotional support is very important. But again, the detail is not important. The point is that there is evidence about what we can do. Education. We all know that there is a strong relationship between education and health. This is taken from the Commission's report looking at Korea, but we can take it from anywhere. What works there? Again, the point is there is evidence. Good schooling, but things like after-school programs, no demonstrable effect when we subject it to rigorous evaluation. Parental involvement interventions do work, however, but this is related to the nature of our welfare state, to employment and gender, and to all sorts of other things. Education and training for parents is a good thing to help them to support their children, and rewards and incentives for children is a good thing. And this is from a systematic review, it's not just from one study. Again, the Campbell collaboration. So we do know that there are things that improved education. The Head Start program, a nice example of a rigorous evaluation from the United States. A preschool program for children from poor families, launched in the 1960s. Very early evidence of benefit when children entered school. The children who enrolled in this, and these were low-income, predominantly African-American families. The children that enrolled in those programs had better numeracy and literacy when they went to school, but there was some evidence that those benefits faded out over time. What do we see in the long term? Well, that preschool education did have a beneficial effect, slightly different according to race, but generally beneficial. Participation was associated with significantly increased probability of completing high school, many years later, of attending college, and elevated earnings in their early 20s. So after 16, 17 years, still in effect. For African Americans, a significant reduction in being charged or convicted of a crime. And spillover effects, beneficial effects, reminding us of the difficulty of looking at interventions or evaluating these types of interventions, because the benefits may not simply come to those who are the subjects of the evaluations. There may be a wider beneficial effect where things work. Improving access to essential services, the third strand of Dahlgren and Whitehead's taxonomy. Difficult to study, because access to care is a complex phenomenon. It involves relationships over time. Many of the studies have looked at the uptake of single interventions, non-urgent surgery, acute infections, that sort of thing. But the challenge we now face is high-quality access to care for people with complex chronic diseases, where they build a relationship with the team of healthcare providers, multidisciplinary team. Decisions on access to care are often not just made by individuals, but by families and friends. It's not just enough to live beside somewhere. It's not just a geographical question, and the evidence is clearly contextually bounded. You cannot simply apply it from one place to the other. But again, there is evidence. The detail does not matter. The point is that we know what works and what doesn't work, and if we can direct this at those people who are in most need, then we can get some benefit. Cervical screening, invitation. I hesitate to talk about cervical screening in Germany because, of course, you do vastly over-screen people here compared to many other countries, but that's another issue altogether. And don't get as good results as countries that screen much less, but we can come back to that in discussion perhaps. Mass media can be beneficial, and these are from the Cochrane Review, so that's where you look to for the evidence of that. In primary care, an interesting study recently looking at the way in which we reward and incentivize healthcare, a qualities and outcomes framework, where there is a targeting of payments to the provision of effective preventive services, measuring blood pressure, getting it under control, and so on. And by making sure that it is recorded and followed up, that has had a very beneficial effect on reducing inequalities. And we move to the fourth strand, and the fourth strand is the encouragement of macroeconomic and cultural change. A slide that will be very familiar to you. It's from Michael Marmot's presentations from his report. And it reminds us that if we look at the percentage of the population that are in poverty, which is the height of the bar, the red and the blue together, then a country like the United Kingdom or a country like Italy has a significantly higher proportion of people in poverty before we take into account transfers and redistribution of money. But by the time we redistribute money from taxation into benefits, then we have reduced the number of people in poverty. In contrast, the United States, before transfers, is actually doing relatively well. It's sort of about the middle. But because they transfer so little of the taxes from the rich to give to the poor, then at the end, the final result for those affected is that they are worse off, so you have a higher level of poverty. The other finding, which is from a very recent study, which I thought was interesting, is that welfare regimes do matter. And this is maybe a complex graph. I hope you can see it at the back. But what it does is to compare the odds of being in poor or fair health, not good health, in people who are unemployed compared to those who are in employment. Now, I'm skipping over a huge amount of detail because we know there are selection biases, we know there are all sorts of issues in interpreting these data. But the fundamental finding is that if we look at the welfare state, types of welfare state across Europe, and there are many problems in categorizing countries into welfare states, into typologies, because all of them are different, very fundamentally different, but this is a very broad classification. And what it suggests is that in the Anglo-Saxon country, Britain and Ireland, the odds of being in poor health are quite a lot higher, almost 3 times higher than if you're in employment, for both men and women. In the Bismarckian systems like Germany and Austria, the problem is primarily one for men, and in the Scandinavian countries it's primarily one for women. In contrast, in Southern Europe and in Eastern Europe it's much less of a problem. Well, how do they explain this? These explanations are highly speculative. We don't know the answer because it's a recent study, the findings were unexpected. But they do provide some suggestions. The Anglo-Saxon systems are simply mean. Low wage replacement levels, means testing. We don't give our unemployed very much and we highly stigmatise them. The Bismarckian systems they suggested, and it's only a suggestion, emphasise the role of the male breadwinner. The family structure, it's the man who is expected to go out to work. Going back to the origins of the Bismarckian social insurance system in the 1850s, 1860s. The Scandinavian systems are very generous, and they're known to be very generous in particular for families. So it's very easy for mothers to spend a lot of time out of work after they have babies, have long interruptions, and their maternity benefits are good, but then they are not building up their contributions and their entitlements for when they lose their job for other reasons, and they may be disadvantaged. The Eastern systems and the Southern European systems were never very generous, and the argument is that perhaps that allowed informal mechanisms, family support, to take over some of the role of the state and cushion the impact of unemployment. I don't know, but it just seemed like an interesting comparison. Well, now let's look at some of the broader things that can be done. And this is from a paper by Johan Mattenbach and colleagues looking at some of the policy innovations that have been proposed to reduce inequalities in health. What do we know about them? An attempt to steer policy by getting a map of where we want to be. An attempt to navigate, to say, we want to narrow the gaps in our society. Quantitative targets, reduction. So the Dutch strategy to reduce inequalities in a number of intermediate outcomes, poverty, smoking, working conditions, and so on. Health inequalities impact assessment, to say that when we introduce policies, we should subject them to an assessment of the impact, not on health alone, but also on inequalities in health. But the difficulty is that we have very little evidence that this works. It's probably a good idea. We don't know that they don't work, but also we have little evidence that they actually do work. But that doesn't mean we shouldn't keep trying. Johan's second category was interventions looking at labour market and working conditions. And he compared universal approaches, strong employment protection and active labour market policies for people who are ill, occupational health services as a core part of the welfare state, or more targeted approaches. He used an approach of job rotation among dustmen or refuse collectors in the Netherlands. A lot of work now linking shift work into poor health. And to summarise a wealth of literature, there is some evidence of effectiveness. And emerging work, and including a paper that we've just completed looking at the impact of economic recessions in Europe, that active labour market policies, keeping people in work, during times of financial crisis may be highly protective. It may be one of the most protective things we can do in terms of their health and their premature mortality. So there is evidence emerging there. But again, it's incomplete. What about health-related behaviours? Well, this goes back to my earlier presentations, the earlier part of the presentation, so I'll just summarise it briefly. The universal approaches, the targeted approaches, some narrow inequalities, some don't. Some work in terms of improving general health, some don't. But again, evidence that we can draw on in trying to define what policies might be. And then the territorial approaches, Johann's fourth categorisation, comprehensive strategies, community regeneration, the health action zones in England. Here we have a systematic review of 19 studies, and here the evidence is more depressing. I quote, "There's little evidence of the impact of national urban regeneration investment on socioeconomic or health outcomes. Where impacts have been assessed, these are often small and positive, but adverse impacts have also occurred." Seems like a good idea, but the evidence is not particularly supportive for this type of approach. So maybe we can move back a bit and ask some of the fundamental questions as we're moving ahead to look at health strategies. In the United Kingdom, Tony Blair very famously said once that he would be tough on crime and tough on the causes of crime. And here the issue for us is being tough on ill health, or tough on the causes of ill health. Where do we want to intervene? Do we decide that we're going to take a very narrow health focus and we're going to tackle just the immediate causes of ill health, tobacco, alcohol, poor nutrition? There's nothing wrong with that, because there's a lot to be done there. There still is a huge amount to do, like getting bans on smoking in public places everywhere. On the other hand, some people will think that this is just a sticking plaster. It's not addressing the fundamental problem. Do we want to change society fundamentally? Two different views, but not necessarily opposing views. They can be complementary views. But the key in all of this, I think, is to remember that just because probably everyone in this room has agreed that we need to tackle inequalities, not everybody else is. The Economist, writing in about 8 years ago, "Does inequality matter?" And a quotation I took from a BBC website after Hurricane Katrina. Paul Krugman had written in the New York Times that the problem with Hurricane Katrina was that after 10 years of denigrating, of attacking government and saying government was useless, then when you suddenly need a government, you find that it can't deliver. But someone else wrote, and this is from the United States, "Shame on anyone that makes this tragedy political, socioeconomic, or racial. In the land of opportunity and personal responsibility, the individual is ultimately accountable." And the picture I have shown is from New Orleans. It's not from Rwanda, it's not from Liberia, it's not from Sierra Leone, but it's from New Orleans. I don't need to remind this audience that medicine is a social science and politics is nothing but medicine writ large. So to summarise, I haven't answered the question that I was set, because I don't know that it's, at this stage, a question that we can answer. But what I hope I've done is conveyed to you that there are many, many inequalities in health, on many dimensions, and taking many different forms. What you do, what you or you or you or you or someone else out there does, depends on who you're trying to help, because there are a lot of people out there who need help, a lot of different people. What the problem is, because they will have different problems, and where you, as an individual or an organisation, can intervene. If you're a housing association, intervene in housing. If you're a school teacher, intervene in education. Don't try and do everything. Then you can ask what works. And fundamentally, I hope that what this talk has done is to say there is evidence out there. Not to answer the big questions, how do we make society fairer? That's a question for the politicians. That's a question that you help to decide when you vote at elections. That's one of the big questions. We can't deal with it as public health professionals. But there is evidence out there and things that we can do. And when you do something, please, please, please evaluate what you do and tell the world. Write it up in a peer-reviewed publication so we can find it, so that we can know if it really did work and we can learn from your experience. Thank you very much.